Thank you very much. Can you hear me? So it's very difficult to come actually after the professor, and very, very interesting, essentially immuno-oncology, very, very impressive. So I'll skip through those slides that have to touch on using stem cells in the field of immune oncology. So essentially the field of regenerative medicine, it's a discipline that aims to replace or regenerate damaged tissue to restore the normal function, and that's, or at least partially improve the function. We may not be able to achieve this fully, but at least improve to some extent. And I borrow also the initial, this slide is rather common in the initial Greek mythology. Zeus, there was a punishment for one of the people who were not behaving well, and they had this bird eating their liver on a daily basis, and every day it would regenerate, and they go and be tortured again the following day. So they use this slide to just underscore the fact of regeneration, and liver is one good example of organ that is able to regenerate. So the quick definition of stem cells, so we remove the mystery about it. Essentially, two more definitions. Essentially, the ability to formulate different kinds of cells, and we'll allude to what level exactly different cells, and to replicate and divide. They say indefinitely, but it's really not indefinitely, multiple times. So many sources that we have of the stem cells, I'll touch on the source as we come to the embryonic stem cells source and IVF. And the one that Professor alluded to, the induced pluripotent stem cells. Credit goes to Professor Shinya Yamanaka from Japan. And multiple perinatal sources of stem cells, including the amniotic fluid, wart and jelly, and the placenta, and different adult stem cells which reside in different tissues, and they tend to be tissue specific. So going back to embryology, just want to let you know about where do they get these embryonic stem cells from. One, after of course, the cleavage, the initial cleavage, and reaching up to 16th cell stage, there is this orange fluorescent inner cell mass, and that's where they capture it from. Typically, when we have many centers of IVFs all over the place, and as you know, you need only one egg, and there is some discarded eggs, so this is usually the source where they get the embryonic stem cells from. Ethically, we're not using that here, in many countries of the world, they don't use it. But this is just a quick emphasis on the potency of the different cells. So the initial fertilized egg is called totipotent. It can lead to, of course, the embryo to begin with, and all the kinds of cells, different lines of cells. And the pluripotent, the three layers, endodermal, mesodermal, and ectodermal. And initially, as the cells progress, it becomes limited in the potency. It's usually able to generate mostly the tissue where it came from. And this is the umbilical cord stem cells. Comes from the wart and jelly, and I believe we do have many, embryonic, cord blood banks here in Dubai, and I think that more and more people are getting comfortable with the idea of preserving the fetal tissues, fetal blood, and embryonic stem cells for future use. And I just have to give you this is a picture of Professor Shinya Yamanaka. In 2012, he won the Nobel Prize, and he was the one who was able to create these pluripotent stem cells, not from embryo, but typically they from fibroblasts from the skin, one cell from the skin, and these specific factors, they call them the Yamanaka factor. It looks simple, but it actually took them very, very long time, so many trials to be able to reach this cocktail, OCT3, 4, SOX2, KLF4, and CMYC. And this is how to prove the pluripotency, essentially specific markers, but also they have to show that they're able to produce the three endodermal, mesodermal, and ectodermal cells. On the practical side, in the US, in Wake Forest Institute in Winston-Salem in North Carolina, Professor Anthony Atalla, I think it was only one experiment was not able to be replicated afterwards. He was able to generate a bladder for a patient who did not have a bladder and he had renal kidney failure. and they were able to place it in the patient. So it became very prominent, but not reproducible. On the concept of bioprinting, as we'll touch on that, there's typically, timeline. The professor mentioned, his research goes back to 30, 40 years. So it does take a very long time until you're able to achieve. But the bioprinting is one of the things until you do the clinical studies. The commercialization, again, will take another 10 to 15 years. But essentially, the idea of biobank is you use the specific cells, culture, expand them, and then you place them in almost like a gun that places a cell in the tissues where it's cartilage or what have you. The potential for effect of those cells, part of it is angiogenesis, especially like in diabetic people who have diabetic vascular disease, anti-apoptotic, and then if in the case of nerve cell, neural differentiation, and the trophic factors, as will come later on, because we know that many of the cells that we inject, like mesenchymal stromal cells, they degrade very quickly and release what we call trophic factors that help the therapeutic effect. This is a good example of a foot, with diabetic foot, that was treated, and we see some resolution of the wound as well. This is the concept of bioprinting. Again, this is courtesy to a lab of Professor Anthony Atalla, how they create, of course, he always mentioned cell flat lines like skin, much easier, followed by hollow organs like bladder, for instance. And the most complex one, like liver or kidney, much more complex. Essentially, they program it and they inject the cells layer by layer to form that. And this is a slide that used before, how to print the kidney in 7 hours. A bit of extreme, but just to give you an example of what are they looking for. And this is, again, Professor Atalla in a TED talk long time ago, holding a bioprinted kidney that he did in his lab. The other concept that before, of course, he's a surgeon, he's a urologist. So before they put any organs back in the body, they did it, I believe, only one time with the urinary bladder. They have to train that organ outside so that they are more or less conditioned to function the same way after they get placed in the body. Like a blood vessel, for instance, this one, they keep stretching the blood vessel like contraction and relaxation, mimicking what this graft would do inside the body. Another cross-section of, again, a vascular tissue. So typically, ministries of defense, they tend to invest quite a bit in this industry because of course, you see the burns, the trauma, orthopedics, loss of bones. So you do need to replace or have a solution for those organs to be replaced. Skin graft is one example, and they use the laser scanner. They determine the topography, what's the defect, and then they inject depending on the defect, one layer by one layer. The bone scaffold is also one example of using this one. Drug testing is also another possibility. I believe the following speaker will also speak about disease modeling, and I will leave that part to them. The concept of immunity, essentially, if you take the scaffold alone, this is the heart, and removed all the cells. They kept only the actual structure of the heart without cells. And this decellularized heart will not induce immune reaction. And then they inject the cells. And that's the concept of using the patient's own cells on an inert material to create an organ. But this is a bit far-fetched at this stage yet. The one part I want to focus on is the diabetes, because there's been a tremendous success with this part, and it's going from different parts of the world, and I think there's a lot of success in this area. Dr. Professor Camillo Ricordi, another great scholar in the field of diabetes, spanning 40 years. You see, his research goes back to 1986, and almost 40 years now until they reach the level of placing cells without the need to use immunosuppressants, and this is a great accomplishment. It started with something called Ricordi chamber. Essentially, they get the pancreas from a donor, and because they want only the beta cells, they don't want the other parts and they go through this process where they extract the beta cells through different parts. And he had, of course, patents approved for his what they call Ricordi chamber. And this is the beta cells with a different kind of cells that we have there. It has endocrine and exocrine. This slide summary, summarize almost 40 years of research until the very late submissions and publications from England Journal of Medicine, showing sustainable glycemic control, especially in brittle diabetics, with these transplanted cells, without the need to use immunosuppressants, which is very, very important, because the old days you had to use, with islet cell transplantation, you had to use immunosuppressants to prevent rejection. Again, this is an example of the recorded chamber and a summary of what they're doing. Essentially, they place the cells in the recipient's liver. Picture from the lab as well. The initial protocol was created in Canada, called Edmonton Protocol, and Professor Shapiro, along with Professor Ricordi, were involved with this trial. Another concept in treating diabetes was the cell pouch. When they produce essentially you want to shield the cells from the immune system. So that cell pouch under the skin that would harbor those cells, and there's ongoing trials of this one as well. Disease modeling, I will leave this part to my colleague, but there is an ongoing conference next door in Qatar about disease modeling. Essentially, the idea of bringing from the patients with specific disease one cell and going back to the induced pluripotent cell, and then creating, if it's a disease with the lung, they will go to form a lung that has the disease, or liver, what have you. And Dr. Milton, also at Harvard Stem Cell Institute, he was a leader in this area as well. In interest of time, I have to fly. Essentially, this is the trials for the artificial pancreas, but we'll focus on the stem cells. Recently, this stem cell-derived publication, glycemic control over a year after using those cells. And then you're familiar with the CRISPR-Cas9 or gene editing tool. It's like a molecular scissor. It edits the molecule, and using this technology, they were able to transplant allogeneic beta cells without using immunosuppression. This is a clinical trial we did at SSMC regarding use of mesenchymal stromal cells and aging frailty. Looks promising. Again, I will not. This is also using the PD-1. I think Professor has alluded to the use of immune modulated cells. Then I had to shift gear in the remaining 2 minutes to gene therapy. Essentially, Professor talked about using the varicella virus for vaccinemia. Most of those cells, gene therapy now are using adeno-associated virus. And the whole, as he mentioned before, it has to be non-integrating in those cells. So essentially, the first patient was combined immune deficiency, which is a nasty disease with high mortality. This was the first patient to receive that one. FDA approved so many gene therapies have approval. A good example of sickle disease, we have 2 approved sickle disease medications. Essentially, you collect the patient's blood with the stem cells, and you have to you add the beta globin gene from the viral vector, and that will shift hemoglobin S to fetal hemoglobin, which does not cause the sickling. And again, this is for the hemophilia. I initially started with hemophilia B, and now hemophilia A also have treatment in this regard, which is very, very promising. I have to mention those medications are quite expensive, but it's usually once in a lifetime treatment. So you have to calculate it against the cost of healthcare over lifetime of the patient. So if you do it right, maybe the healthcare organizations that monitor this will pay for those for a large number of patients. And that's the concept of the RNA use. Professor has alluded to many times. More than 19 US approved gene therapies already approved by the FDA, which is very, very promising, including spinal muscular atrophy and other. I will skip this one because Professor has alluded to. I want to mention that we have also the American Board of Regenerative Medicine here, coming to UAE as well, for people who are interested. In conclusion, regenerative medicine, particularly the commercialization part, and there is so many people doing that in the market, you have to be careful. Not everybody, you have to check the background and risk and benefit. This is an old map of the US where so-called unapproved stem cell clinics were all over the place. FDA started to regulate, and I think I'll come to the last slide, and I thank you very much for your attention.